Yes, good afternoon, ladies and gentlemen. It is my great pleasure to welcome you to the thematic session number 3, to the management of patients with castration-resistant prostate cancer, and welcome to EAU 2020 virtual. My name is Maria de Santis. I'm a medical GU oncologist from the Charité University Hospital in Berlin in Germany. And it is my great pleasure to co-chair this session with Professor Manfred Wirth. He's a urologist from the University Clinic of Dresden. I think we have a great program today, and I would just like to introduce the format. We will have 3 pre-recorded lectures to begin with, and a Q&A session in between, and then continue with the case presentation, a debate, and a final lecture by Alison Birtle. To begin with, I would like to introduce Lisa Howard from Sydney in Australia, and she will talk about the prediction of response to systemic therapy in CRPC. So let's start that session. Thank you.
I would first like to thank the organisers for giving me the opportunity to talk at the EAU this year. I'm very sorry that I will not be meeting you all in person, as this is my first EAU conference, but I look forward to doing so in future years. Today I will be talking about how we start to tailor treatments in metastatic castration-resistant prostate cancer. These are my conflicts of interest. Before we look at response to systemic disease, I think it's very important to reflect on the significant changes in prostate cancer treatment over the last 20 years. In the year 2000, this was our treatment paradigm: androgen deprivation therapy in the setting of metastatic disease and biochemical relapse, and mitoxantrone and prednisone for palliative relief of symptoms in the metastatic CRPC setting. If you head forward 20 years, the chessboard has changed dramatically. We have 2 different versions of taxanes, docetaxel and cabazitaxel. We have a wide range of androgen receptor pathway inhibitors, including abiraterone, enzalutamide, apalutamide. We are using PARP inhibitors. We are also using bone-directed therapies, denosumab and radium-223, and immunotherapies are starting to be used in this area. A very big change in the last 5 years is the change to the treatment of metastatic hormone-sensitive prostate cancer. We now know that intensification of treatment at this earlier stage of the metastatic journey significantly improves overall survival. Across the world, we are using docetaxel, abiraterone, enzalutamide, and radiotherapy in order to do this. In this presentation, I'm going to concentrate on how biomarkers can tailor treatment in metastatic castration-resistant disease. Imaging modalities will be dealt with later in the session. I think it is important to start with the definition of the different biomarkers and what they are trying to achieve. A prognostic biomarker is, of course, one that is trying to predict an outcome, whether it be a response, a recurrence, or overall survival. A predictive biomarker is very much one that prospectively defines whether a drug is likely to work or not work. And a therapeutic response marker is used longitudinally to identify whether, in this case, a drug is being effective. We've used PSA for many years, and the early elevations or decreases in PSA are variably related to the overall response to treatment. We are certainly looking for better markers in this space. There are a wide variety of ways that we can achieve the holy grail of all cancer therapy, which is precision medicine. The right drug to the right patient at the right time. In metastatic prostate cancer, we have predominantly been looking at tumour samples through both tissue and circulating DNA and circulating tumour cells. There is also the concept of looking at the host through lipid metabolism and the immune system, as optimization of the host or the tumour microenvironment may enhance responses to treatment. Tissue offers a great opportunity to do detailed genomic profiling, as well as other forms of omics, including proteomics and metabolomics. However, we know that the molecular makeup of prostate cancer changes vastly from the primary cancer through to metastatic castration-resistant disease, through not only progression of the disease but change due to androgen deprivation therapy. This means that metastatic biopsies are required, and these can have poor yields given the number of patients that have predominantly bony metastases. There is also the issue of tumour heterogeneity and the sampling bias of taking a biopsy of only one metastatic site. Liquid biopsies have become more popular over the last several years, as they are an easy blood test and have the capacity to look at both de novo and acquired resistance due to repeat sampling. In order to structure this talk, I've decided to look at biomarkers according to the systemic treatment categories. So we're going to start by looking at the taxanes and work our way through the androgen receptor pathway inhibitors and into the PARP inhibitors. The concept of surrogate endpoints is not new. This is the TAX327 study, the randomized controlled trial of docetaxel prednisone versus mitoxantrone prednisone, that was one of the two landmark trials showing improvement in overall survival for men with metastatic castration-resistant disease. The subsequent analysis showed that overall survival was correlated with a greater than or equal to 30% decline in PSA at 3 months. It was also correlated with patients that had had a pain response of more than a 2-point reduction in the pain scale. So this was the beginning of trying to look at therapeutic response. Over the last 10 years, a number of circulating biomarkers of prognosis have been developed and validated. These include circulating tumour cells, which are obtained through sorting through the cell search machine, cell-free DNA, which is measured through next-generation sequencing, and methylated GST-Pi, which is a head-loop epigenetic PCR assay. All of these have been tested in randomized controlled trials of taxanes using baseline measurements. The SWOG study was a randomized controlled trial of docetaxel plus or minus atrasentan, in which high levels of circulating tumour cells were predictive of a significantly shorter overall survival. However, only around 50% of patients had baseline CTCs detectable. The first ANA study was a randomized controlled trial of carbazitaxel and docetaxel as first-line treatment for CRPC. Proselica was a randomized trial of 2 doses of carbazitaxel as second-line treatment. High levels of cell-free DNA predicted for a poorer overall survival. Similar results were seen in the Synergy study of docetaxel plus or minus Castración, in which patients who had detectable methylated GST-Pi had a significantly worse overall survival. All of these assays largely reflect the prostate cancer burden of disease in the circulation. Prognostic markers do not tell you what drug to use. Changes in cell-free DNA and circulating methylated GST-Pi are also associated with changes in progression-free survival after treatment with taxanes. A decline in cell-free DNA after cycle 4 of a taxane correlates with a PSA response. Similarly, patients who still had detectable methylated GST-pi after 4 cycles of docetaxel had significantly poorer progression-free survival, either by PSA or by radiological progression-free survival. The next major group of drugs to address are the androgen receptor pathway inhibitors. The main drugs that have been looked at through biomarkers are abiraterone and enzalutamide, which I will be concentrating on in this talk. Circulating tumour cells have made a great impact as a therapeutic response marker and a surrogate endpoint in this area. This is an analysis of 5 randomised trials, mainly of androgen receptor pathway inhibitors, but also cabozantinib in the COMET study, looking at over 5,000 patients who had sequential measurements of circulating tumour cells. The conversion from high levels of circulating tumour cells to low levels or no evidence of circulating tumour cells has been highly associated with overall survival with small variation. This is in contrast to much lower weighted C indices on the right, looking at PSA 30, PSA 50 as an endpoint. The FDA has now approved CTC conversion as a surrogate endpoint for these types of therapeutic trials. A key question in this field is how can we look at the genomic aberrations and identify predictive markers for which therapy to use at what time. It's important to remember that the genomic landscape changes vastly from localized disease on the right to metastatic castration disease on the left, where there is a much wider array of genetic abnormalities, in particular in the androgen receptor, P10, P53 and TMPRSS-ERG. Recent studies have taught us a lot about the genomic landscape of castration-resistant disease. This is the well-established study from the East Coast DREAM team, looking at 150 patients who had metastatic biopsies prior to commencing treatment for CRPC. The key findings are 70% of patients having aberrations of the androgen receptor, mainly amplifications, more than 50% P53 mutations, and around 50% changes in the PI3 kinase pathway, in particular deletion of P10. Furthermore, around 20% had abnormalities in the DNA repair gene pathway. Similar findings have been identified in circulating tumour DNA, with widespread changes in the androgen receptor, in particular amplification, changes in the PI3 kinase pathway, and changes in DNA repair. So how can we start to look at these genomic aberrations in terms of the treatments that we are giving patients? This is a study from the Vancouver Cancer Centre looking at more than 200 patients who were treated with CRPC, either with abiraterone or enzalutamide. When controlled for other clinicopathological variables, you can see that changes in homologous recombination genes, in particular defects, predict for a much shorter progression-free survival, as do P53 mutations and androgen receptor gains. ARV7, an androgen receptor variant, which is constitutively active, is another potential predictive biomarker that has been extensively investigated. There is still significant controversy as to whether this represents a prognostic biomarker of poor outcome in CRPC, or whether it can truly be used to predict response to androgen receptor pathway inhibitors. Certainly there is an association with poor progression-free survival in patients with evidence of AR-V7 prior to treatment. What is quite important from the recent study is that there has been a significant attempt to validate different assays, as this is a CTC-based assay for AR-V7 detection. The area that has the best evidence for true predictive biomarkers is the area of PARP inhibition. The TOPARP-A study looked at heavily pretreated patients with CRPC and treated them with olaparib. What is very telling is that patients who had homologous recombination repair deficiencies were much more likely to respond to the drug. The subsequent study, TOPARP-B, took 98 patients who already had a variety of these genetic aberrations, mainly homozygous deletions and deleterious mutations, and randomised them to 2 doses of olaparib. It demonstrated that different mutations had different rates of response to PARP inhibitors. BRCA1 and 2 mutant cancers were much more likely to respond to the olaparib, while CDK12 aberrant cancers were much less likely to respond. This is allowing us to drill down in a great deal more detail into the genomic subtype matched to the treatment. A key element, as you can see from this presentation, is how do we move these biomarkers from early stage development, i.e. from the lab, into the clinic. There are 3 very important steps. Analytical validity. Does the test actually measure and test reliably and robustly what you think it's measuring? Does it have reliability in multiple patient cohorts, both internal and external validation? And the final and critical step, is there actual clinical utility? Does it lead to improved outcomes? And this is one of the hardest parts of the journey to the clinic. So in conclusion, what do we have here and now that can predict response to systemic therapies in metastatic CRPC? At the moment, we have CTC enumeration on an FDA registered platform in terms of cell search. We also have the HRR defects or DNA repair defects for PARP inhibitors. This is mainly done on tissue, and there are assays also in liquid biopsy form, which are going through the process of development. However, the key now is ongoing research. Tissue genomics are largely being used for clinical trials of targeted therapies against the potentially activated pathways. ctDNA is being used for umbrella studies such as the one that is being done through the Canadian Cancer Clinical Trials Group. ANZUP in Australia and New Zealand is doing a prospective study with methylated GST-Pi to guide docetaxel therapy, and there is significant potential for the immune and metabolic biomarkers to guide therapy that may complement standard of care treatment. It is an exciting time, and I look forward to seeing how these new biomarkers roll out in the future.
Yeah, thank you very much. A big thank you to Lisa Horvath for this comprehensive overview about predictors of response and the biomarkers in CRPC. And now it's my pleasure to turn the chair to Manfred Wirth to introduce the next speaker.
It's also my pleasure to introduce you as the next speaker and to co-moderate with Maria de Santis. And the next speaker will be Professor Wolfgang Leutel from Linz in Austria. There's a chairman, and he is an expert in castration-resistant prostate cancer and imaging. And he will speak about imaging of castration-resistant prostate cancer, what is possible, what is necessary.
Dear colleagues, dear chairlady and dear chairman, I thank the organizing committee for inviting me to give this talk on this very interesting topic. These are my disclosures. Imaging of CRPC, what is possible, what is necessary. I will turn it round. What is necessary is first. Imaging in CRPC has recommendations. Considering the disease state and clinical scenario, imaging should guide treatment or even change clinical decisions. 3 questions to answer. When and what type of imaging is appropriate and in which scenario? When should imaging be performed? The Advanced Prostate Cancer Consensus Conference 2017 in St. Gallen recommended in its guideline that imaging be performed at baseline, PSA nadir, and progression at least in patients with usual presentation. What scenarios are to be discriminated in CRPC? Primary non-metastatic M0 CRPC, primary metastatic M-CRPC, or recurrent metastatic M-CRPC. What is the importance of imaging in CRPC? As recommended by the Prostate Cancer Working Group consensus statement, PSA progression alone for men on treatment of metastatic CRPC should not be the sole reason to change therapy. The importance of imaging in CRPC in all the studies. Based on this grown knowledge, a new endpoint for clinical studies in CRPC was created. Radiographic progression-free survival, RPFS. A new era started by approval of more than 8 drugs in the last couple of years in the treatment of CRPC based on positive studies including the radiographic progression-free survival as endpoint. This era is still ongoing. The Prostate Cancer Working Group had defined the criteria for radiographic progression, like in this patient. We do see at week 9 2 new lesions. They had to be confirmed in a new scan, but there was no progression. 20 weeks later, new spots are coming up, and these have also been confirmed by a second scan. Then there is radiographic progression. What imaging tools are available? We have CT, we have bone scan, we have MRI as the conventional imaging, we have PET, we have whole body MRI as the next generation imaging, NGI. Limitations for CT, we all know this. Relatively poor performance for detection of bone metastases, limit assessment in lymph node metastases with a sensitivity of 42% and a confidence interval of 20 to 56%, a specificity of 82%. The MRI is a very much longer examination with 20 to 30 minutes, whole body would be 60 minutes, detection of lymph node metastases with the same morphological features assessed on CT, a sensitivity of 39%, a confidence interval of 19 to 56%, a specificity of 82%. Limitations of bone scan. As we have heard, new bone formations responding to therapy can appear as a new lesion, so-called flare response. As a result, the Prostate Cancer Working Group had these guidelines requiring new bone lesions to be seen on 2 consecutive scans, a new lesion to be seen on a second scan before progression can be called. Inherent delay to the need for confirmatory scans we do have, difficulties to quantify disease and therefore track progression. Now the new kid on the block, PSMA ligand PET for early castration-resistant prostate cancer. This is a retrospective single-center study of Germany from Manuel Weber and his group. And he showed in PSMA PET scan that it was positive in CRPC in 75%. 29% had local disease only, and 45% had M1 disease only. The same group undertook a trial of 200 patients, and these 200 patients were high-risk M0 CRPC patients, like they were put into these new trials, the old trials that we had for the new drugs. PSA doubling time smaller than 10 months, Gleason score then greater than 8 only. And we can see that M1 was 55%, 109 patients in this criteria. 58% in patients with a doubling time, and a greater 8 Gleason score, it was 49%. They had now new criteria, the promise criteria for modern imaging. Do we create a new entity? Yes, we do. We see patients with modern imaging 1 N1 as a small lymph nodes, and two regions. We see patients with metastases in the lymph nodes or visceral metastases in 1C, and we do see a bone metastases 1B, oligometastases, or even disseminated metastases. The discrimination of metastatic CRPC from M0 CRPC, what say the EAU guidelines? The evidence shows that the choline PSMA, PET-CT, MRI provide a more sensitive detection of lymph node and bone metastases than the classical workup, associated bone scan and abdominopelvic CT scan. It could be tempting to conclude that bone scan and CT must be replaced by more sensitive tests in all patients undergoing initial prostate cancer staging. Yet the clinical benefit of detecting metastases at an earlier time point remains unclear. So we do have a dilemma. The prognosis and ideal management of patients diagnosed as metastatic by these more sensitive tests is unknown. In particular, it is unclear whether patients with metastases detectable only with PET or MRI should be managed using systemic therapies, or whether they should be submitted to aggressive local metastasis-directed therapies like surgery or radiotherapy. M0 CRPC in PSMA PET, the data of Spartan, Prosper and Aramis trials have shown that the treatment of high-risk M0 CRPC patients with systemic therapies added to ongoing ADT can delay the transition to metastatic CRPC. Therefore, metastatic disease on PSMA PET only should not be per se disqualify patients from receiving treatments with androgen receptor inhibitors. So we have limitations for PET-CT MRI regarding PSMA PET tracer, and there's a big body of heterogeneity of PSMA within these patients. Johann de Bono made this landmark work published in the European Urology last year. He told us that the expression of membranous PSMA at diagnosis was associated with higher Gleason grade, worse overall survival. PSMA expression levels increased at metastatic state. Castration-sensitive prostate cancer was the level 17.5. versus metastatic CRPC 55. Surprisingly, 42% of castration-sensitive PC and 27% of metastatic CRPC tissues sampled had no detectable membranous PSMA. Marked intratumor heterogeneity of membranous PSMA expression with foci containing no detectable PSA was observed in all membranous PSMA expressing CSPC and in 84% in metastatic CRPC biopsies. You can have a look at the distribution of the membranous PSMA expression. In CSPC, it's much lower than in CRPC, but you can see the heterogeneity between the metastases in the bone and in the lymph node. The distribution of PSMA is totally different, and within one biopsy of one tumor, the intratumor heterogeneity was very, very visible, and for treatment reason, it was measured by millimeters, so you can see that this the difference between longer than 2 millimeters from one PSMA positive to a PSMA negative area. So conclusions. These findings explain negative PSMA PET-CT results in MRS mCRPC in 10 to 15% and the rate of non-responders to a PSMA ligand therapy of 30%. So clinicians cannot rely on PSMA imaging alone in metastatic CRPC. These facts lead to the question, what is possible in the field of imaging in CRPC? Is there a space of additional imaging modalities? What is the need for them? Are there any future aspects? Additionally, regular imaging monitoring is more likely if there is an aggressive variant, including small cell and neuroendocrine. We do have FDG PET, DOTANOC PET, and they will have more information. This nice work from India shows that there is a patient with 160 PSA and adenocarcinoma of the prostate undergo ADT therapy and had a PSMA PET with just local progression, no metastases. It was resected, and in the resection of the local TUR specimen, there was neuroendocrine differentiation. They undertook DOTANOC PET-CT, and there you can see a lot of metastases, and the FDG PET shows us the same. Exclusively visceral metastases do have a hard recommendation for additional imaging in CRPC. Also, predominantly lytic bone metastases, bulky disease, PSA very low at the beginning or negative even, presence of neuroendocrine markers in histology and serum, see a short interval of androgen therapy progression. So the take-home message is the non-metastatic CRPC. The new generation imaging can be offered only if a change in the clinical care is contemplated. Assuming patients have received or are ineligible for local salvage treatment options, this new generation imaging may clarify the presence and absence of metastatic disease, but the data is limited for the capabilities. For the metastatic CRPC, when we have clear evidence of radiographic progression on conventional image, while on systemic therapy, new generations imaging should not be routinely offered. The NGI may play a role if performed on baseline to have comparison in the imaging findings on progression of disease. Conclusions and pitfalls from Ian Davis. This group in Australia has done a lot of work on PSMA PET scanning and PET scanning at all. There's a clearly a value on PSMA scanning Sometimes there are no added value to management plan, often clinical situations where PET results will not alter the plan. PSMA PET comes frequently incomplete decision making with the context, lack of history, no parallel FDG PET. The CT component has a low diagnostic quality. And there's a new thing going on. We have patients distraction and new PSMA neurosis coming up. What will be possible in the near future? Upcoming studies, trial with blinded PSMA, PET-CT, and conventional image are done so far. Trial with immunopet is coming up. A lot of studies are here on this table with all components and all kinds of checkpoint inhibitors like atezolizumab, avelumab, durvalumab, pembrolizumab. You can see all these nice pictures where you can find out the checkpoints when they are able to be detected. And you can also manage the treatment when you see that this will disappear. However, this presence of single immune checkpoints is likely an oversimplification of factors determining immunotherapy response. This PD-1, PD-L1 imaging may give a more accurate representation of whole body expression of these compared with immune histochemistry PD-L1. But its role as predictor remains to be determined. It would be very relevant to explore the feasibility on treatment imaging, assess the dynamics of this anti-cancer treatment. Future imaging aspects are, for example, CD8 plus T cells imaging using antibody fragments, allowing direct assessment of the location and density and proximity of CD8 plus T cells, like granzyme B is a serine protease released in CD8 plus cells and natural killer cells. These are key markers for immune cell activation, and this PET imaging can visualize and quantify granzyme B. The identification of active tumor infiltration lymphocytes to monitor the therapeutic efficacy of immune therapy could be done. So it's a very, very, very thrilling area that we are going. And the only main issue that we have is the bewildering heterogeneity of the tumor. And we see that in a lot of ways and a lot of therapy regimens and lines. But the imaging will be one part of this puzzle, but with increasing importance. Thank you very much.
So thank you very much for this great talk, Wolfgang. And now it is time for pathology, our third lecture in the first block. And I would like to introduce Sven Perner. He's professor of pathology and chair of the Department of Pathology at the University Clinic in Lübeck in Germany. And he will talk about molecular pathology before systemic treatment, what is feasible.
Hello everyone, I would like to thank the organizers to include me as a speaker in the thematic session 9, Management of Patients with Castration-Resistant Prostate Cancer in 2020. These are the disclosures I have to make as a potential conflict of interest. I would like to talk about the topic molecular pathology before the systemic treatment, what is feasible today. And if we look at the molecular subtypes of primary and metastatic prostate cancer, we can state that 3/4 of the prostate cancers harbor gene fusions, mostly involving the ADS transcription factors ERK, ETV1, ETV4, and FLI1. unfortunately, these gene fusions are not actionable. Then very frequent are also mutations in genes like SPOP, FOXA1, IDH1. So far, only for the IDH1, we have an inhibitor for cholangiocellular carcinoma, which is so far not approved for prostate cancer. The molecular subtype of prostate cancers also include actionable mutations in 1/4 of cases with PI3 kinase, MAP kinase signaling pathways, and also in about 20% alterations of genes involved in DNA damage repair. This is already stated in a nicely worked out study from 2015, published in Cell, where the authors used the Cancer Genome Atlas Research Network for their analysis. As we can see in this pie graph, the alterations in the DNA damage repair genes are highly common in advanced prostate cancers. The alterations of BRCA1, BRCA2, and ATM alterations already occur in a little bit more than 10% of primary prostate cancers, and in metastatic prostate cancer we have alterations of BRCA1, BRCA2, ATM, and JAK2 in almost 20% of the cases. And the estimation is that approximately half of these alterations are germline mutations. In a recent study from Verena Seiler, who's been working in our department, she nicely also worked out that mutations in DNA damage repair genes occur frequently in other tumors as well, and she could also confirm the mutations in primary prostate cancer occurring in about 15% of the cases. DNA damage repair genes are necessary for repairing double-strand breaks through the homologous recombination, and as already stated, BRCA1 and BRCA2 are the main genes in this setting, and as already stated, that about 20% of primary advanced or aggressive primary and castration-resistant prostate cancer harbor these mutations in these genes. The BRCA testing needs to be done through next generation sequencing. I will go into this a little bit later during my talk. And there are already a large number of clinical trials working out the role of PARP inhibitors in prostate cancer, sometimes in combination with other drugs. And here, for example, the TRITON2 and TRITON3 trial is also a trial which is being performed here in the Department of Urology in the University of Lübeck. The BRCA diagnostic procedure is that we first have to extract DNA from the paraffin-embedded material. We have to do the next generation sequencing, followed by extensive bioinformatic analysis, and then do a calling if we find no mutation, pathogenetic mutations, or unclassified variants, and then we have to develop a therapy plan derived from BRCA1 and BRCA2 are large genes. In total, they have 48 coding exons with more than 18,000 base pairs. And since there are no hotspots in these genes, that means that the mutations in BRCA1 and BRCA2 are randomly distributed over both genes. We have to sequence the whole genes and have a complete coverage during the next generation sequencing. This also requires a research on bioinformatic platforms for the interpretation of the sequencing variants in order to to estimate if a variant is pathogenic or not, and these are the most prominent databases we have available. And actually we do here in Lübeck, we do a search on all 4 of these platforms. In the meantime, there's also increasing evidence that patients with microsatellite instable high or microsatellite with microsatellite instable high or mismatch repair deficient advanced prostate cancers could benefit from a PD-L1 therapy. The mismatch repair is necessary for base mismatch insertions or deletions, and the genes MLH1, MSH2, MSH6, and PMS2 are the genes involved in this repair mechanism, and that is a testing that can be done with the simple immunohistochemistry, but also with a more sophisticated molecular pathology testing. The estimation today is that 5, maximum 10% of aggressive primary and castration-resistant prostate cancer do harbor mutations or alteration in these genes. The idea would be that these genes or the expression of these genes are a marker for a treatment with the checkpoint inhibitors. This offers the opportunity for a possible application in the predictive examination, e.g. in a large sequencing panel, including the tumor mutational burden calculation and also the extrapolation of the MSI status through molecular pathology but also through immunohistochemistry to control the mismatch repair status. For some clinical trials, we already have results for treatment based on the mutations in the DNA damage repair mechanism. For example, the study by Matteo, where, as expected, the authors found that men carrying mutations BRCA1 and 2 and also PALB2 do better respond to PARP inhibitors. Other studies show that DDR mutation associated with poor clinical outcome on treatment with abiraterone or enzalutamide. Another study, as expected, could also show that DDR germline mutation is associated with a poor outcome. Also, another study showing that DNA repair gene mutation do benefit from a radium-223 therapy, or, as already expected, that patients with DDR mutations are more sensitive to pembrolizumab, the checkpoint inhibition. So, to summarize here, we would say that all patients with metastatic prostate cancer should be offered somatic genomic testing of the tumor tissue for homologous recombination deficiency and mismatch repair defects. All patients with a metastatic regional or very high-risk disease or high-risk disease regardless of the family history should be considered for germline testing, since many of these mutations are germline mutations. In Lübeck, we have already established the testing for somatic mutation for the 2 large genes BRCA1 and 2. We have established the testing for the microsatellite instability. We are in the progress of establishing the BRCA panel and also to test for the tumor mutational burden. Very promising results are from a recent publication where the authors could find in castration-resistant prostate cancer a biallelic loss of the CDK12 which is mutually exclusive with with tumors driven by DDR deficiency, and that CDK12 mutant cases are associated with the elevated neoantigens, and derived from there, the authors hypothesize that CDK12 inactivation in castration-resistant prostate cancer may benefit from immune checkpoint immunotherapy. Another interesting prostate cancer subtype is the neuroendocrine prostate cancer, which is rare, but the authors here from a study which is already almost 10 years old could assess the aurora kinase A and MYC in benign prostatic tissue primary prostate cancer and neuroendocrine prostate cancer, and they found that the aurora kinase A and MYC is overexpressed in particular in the neuroendocrine prostate cancer, and is also amplified on the genomic level. And derived from these results, there's already a phase 2 clinical trial assessing the aurora kinase A inhibitor in neuroendocrine prostate cancer. Another promising gene is the DLL3, which can easily be assessed by immunohistochemistry and is highly overexpressed in neuroendocrine prostate cancer. And the authors could here show that in a nice phase 1 clinical trial that patients do benefit from a therapy against a monoclonal antibody against DLL3. One of the most prominent genes in prostate cancer is the androgen receptor, and in this study the authors assessed for amplification, mutations and splice variants of AR, and could find that these alterations do occur frequently in prostate cancers, and that AR amplifications are predictive for response to abiraterone and enzalutamide. And in another study by Scher et al. From 2016, the authors could show that AR variant 7 predicts therapy resistance against abiraterone and enzalutamide. So AR amplification and expression of AR splice variant 7 are prognostic in castration-resistant prostate cancer. The expression of AR splice variant 7 may also be predictive. However, testing decisions are being made based on ARV7 are not fully clear. So overall, we have to say that tissue-based AR alteration assessment is not part of our clinical routine. With that, I would like to thank everyone for listening. I would like to say goodbye with expressions here from Lübeck in the summer, and I hope to see everyone soon again in person.
Well, thank you very much. This was an excellent overview on molecular pathology for CRPC. We have only time for one question, I think. We have run over a little bit. So we have plenty of questions coming in, but I want to summarize one question. It is for Wolfgang Leudl. So the question is, in patients that are non-metastatic CRPC on conventional imaging, but who have positive nodes or positive bone lesions on the PET-CT, how would you treat those patients? Would you regard them as M0 CRPC or treat them as metastatic ones?
Regard that we should treat them as metastatic, as M1 disease. Therefore, we don't do any bone scan anymore. We do PSMA scanning, and we do FDG scanning.
All right, so you scan all the patients, and you won't stop with a CT and a bone scan and treat the patient as a non-metastatic CRPC with, for example, apalutamide, but
No.
you continue scanning and just try to find the metastasis.
Right. We do a lot of aggressive local treatment, for example, surgery or radiotherapy if it's just locally. But if it's systemic, we do systemic treatment.
One question, Wolfgang. In the past, we did not see so small mets we do now see in PSMA PET testing.
Right.
And these patients have been treated by surgery or by radiotherapy, and they did quite well. Do you still think that these patients should not be locally treated? In addition, maybe radiation of the small lesions we are finding?
We do that. We think on that. Yeah. And I think there are lots of work already done in the past, but we do not have a phase 3, of course. But we do a lot of local therapy, just to expand the time of ADT and side effects.
I agree.
All right. So thank you very much. I think we have to stop that Q&A now because of the sake of time. And I would like to turn over to Manfred Wirth to introduce the speakers of the case debate.
Thank you, Maria. I think it was a very good discussion we had and all the very good presenters. The next are the case presentation, and the first case is presented by Giorgio Gandaglia from famous San Raffaele in Milan.
Dear Chairman, dear colleagues, I'd like to thank you for this invitation. This clinical case will introduce a debate on the role of androgen receptor-targeted therapies in the management of non-metastatic castration-resistant prostate cancer. I have no conflicts of interest to disclose for this presentation. Dr. Morgans from Chicago will discuss the pros of the use of androgen receptor-targeted treatment in the management of non-metastatic castration-resistant disease, while Dr. Bethke from Tübingen will discuss the cons. Our case is a 65-year-old man with a PSA of 5.4 nanogram per ml at diagnosis. He received in January 2016 a prostate biopsy with the diagnosis of a grade group 2 prostate cancer in 5 out of 18 cohorts. The digital rectal examination was negative and no pathologic findings were detected at preoperative staging. The patient was referred to our center for surgical treatment. He received a robot-assisted radical prostatectomy in June 2016, and here you can see the final pathology results. A grade group 4 prostate cancer was detected with extracapsular extension. The tumor volume was approximately 20% and the surgical margins were negative. A pelvic lymph node dissection was omitted in this case due to the presence of a risk of lymph node invasion below 5% at preoperative evaluation. The first PSA after surgery was undetectable. However, in January 2017, we detected a biochemical recurrence with a PSA of 0.25 nanogram per ml, which was confirmed in March, and the PSA was 0.6 with a PSA doubling time of 1.4 months. The patient was candidate for salvage therapies, and in particular, salvage radiotherapy was administered to the prostatic fossa and the pelvic lymph nodes. Concomitant androgen deprivation therapy was started with a LHRH agonist. In January 2018, the PSA was 0.1 nanogram per ml, and we observed a rise in the PSA values from 0.3 in March to 1.2 in June, and in August it was 1.5 with a PSA doubling time of approximately 2 months. The total testosterone was 15 nanogram per deciliter. This patient should be then considered as affected by castration-resistant prostate cancer according to the EAU guidelines. A multiparametric MRI was performed to assess the presence of local recurrence and was negative. Similarly, bone scan and the abdominal CT scan were used to assess the presence of distant metastases, and both these imaging modalities were negative. The first question we should ask ourselves is, should we perform additional molecular imaging such as a PSMA PET-CT scan in this patient? Well, when we look at prospective randomized phase 2 trials assessing the role of novel antiandrogens in the management of non-metastatic castration-resistant prostate cancer, we can see that the inclusion criteria were based on CT scan and bone scan. However, the treating physician decided to perform a PSMA PET-CT scan, and 2 positive spots at the level of the common iliac and presacral lymph nodes were detected, as you can see in these images. Should we consider androgen receptor targeted treatments in this patient? Well, according to the EAU guidelines, apalutamide, darolutamide, or enzalutamide may play a role in this setting. We should also highlight that the use of molecular imaging and PSMA PET-CT scan is recommended if the results will influence subsequent treatment decisions. We will now discuss the pros and cons of androgen receptor targeted therapies in the management of non-metastatic castration-resistant prostate cancer. Thank you.
Sure. Great presentation and great case. Pretty straightforward on the one hand, but I think Alicia Morgans will tell us more and why she is in favor of treating those patients. And with that, I would like to introduce Alicia Morgans, Professor of Medicine from the Lurie Comprehensive Cancer Center of Northwestern University in Chicago. Welcome, Alicia, and we are looking forward to your lecture.
Hi, and thank you so much for the opportunity to speak with you today about systemic therapy for M0CRPC in the setting of these very tricky cases regarding enhanced imaging. These are my disclosures. And this is an outline of what we'll discuss. We'll talk about imaging and the issues that actually can cause as we're trying to identify which bucket our patient falls into. Then we'll review metastasis-directed therapy and the lack of evidence therein. We'll move on then to the level 1 evidence that we have and guideline recommendations for intensification of systemic therapy, and then we'll wrap up at the end. So we heard a presentation about this particular patient who had conventional imaging that was negative for metastases, bone scan, and CT scans, but who had a PSMA PET that demonstrated some lymph nodes. And this is not uncommon in today's era. So why is this even a question that we're debating? I would say it's probably related to the differences in imaging that we have around the world, and also related to the phase 3 trials that we have that demonstrate the benefit of systemic therapy, because we know that conventional imaging scans, technetium bone scan and CTs, are going to be negative for many of these patients, including the one we have. But the PSMA scan demonstrates a few lymph nodes, and that makes us want to potentially do more in terms of local therapy. But regardless of molecular imaging results, patients with a rising PSA on ADT with negative conventional imaging actually meet the trial definition of M0CRPC, and they would be included in those trials if they had a PSA doubling time of less than or equal to 10 months, indicating this high-risk population who's likely to die of metastatic prostate cancer ultimately at the end. So is this patient M0 CRPC or oligoprogressive low volume metastatic CRPC? Is it possible that it could be both diagnoses that apply to this patient? And does it ultimately matter given the evidence that we have? M0 CRPC occurs in patients who have had prior treatment of the primary cancer and now have a rising PSA despite ongoing ADT. They have no radiographic evidence of metastatic disease on conventional imaging, and they have castrate levels of testosterone. A very similar population is this oligoprogressive, oligometastatic CRPC patient population. These patients have a limited number of metastases, typically defined as less than or equal to 5, and a rising PSA despite ongoing ADT. They have evidence of metastatic lesions, and this is where it gets tricky, either on molecular imaging or conventional scans, and they have a castrate level of testosterone. So we can see that there is a fair amount of overlap in these populations, and imaging advances actually lead to a merging of these patient groups. We saw in recent evidence that patients who were enrolled in the high-risk non-metastatic CRPC patient phase 3 trials actually were patients who probably have metastatic disease. Interestingly, in a study of imaging, 200 high-risk non-metastatic CRPC patients were enrolled, and out of those 200, 196 had metastatic lesions that were identified on PSMA PET, 98% of them. 55% of these patients had distant metastatic disease. And these were all patients who would meet criteria for enrollment in Spartan, Prosper, or Aramis. So this is a patient population that would have been treated in those studies, but who on molecular imaging had evidence of metastatic disease. So what are the options for our patient? Metastasis-directed therapy, as I mentioned, is very attractive. This is an option for some patients with M0 CRPC or metastatic CRPC, low volume. Importantly, there are not very many studies on this, and I'll just highlight a few. The first is a retrospective analysis that targeted the ablation of less than or equal to 3 sites that were identified either by molecular or standard imaging in this castration-resistant population. What they did was actually calculate PSA doubling time and freedom from progression through modeling, not through measuring these values in their population, which is not standard. But they did find that in this modeling, 73% had a PSA response, and of that group, a mean of 86%, there was a mean 86% reduction of PSA in that population. Again, this was all modeled rather than measured. A second study was a retrospective analysis. Again, this was ranging from 2013 to 2019, in which patients were treated with metastasis-directed therapy to less than or equal to 5 sites, again identified by molecular or standard imaging. 31 patients had the metastasis-directed therapy, 58 did not. Some of them actually had a change in their systemic therapy and metastasis-directed therapy. And metastasis-directed therapy was associated with an improved median time to PSA failure, a time to next intervention, and distant metastasis-free survival. But importantly, the agents that we currently use that intensify our AR targeting actually were not used in clinical practice, so would not have really been incorporated into this retrospective analysis. The challenges are broad and multiple with these studies that we currently have of metastasis-directed therapy and M0 CRPC, or this low-volume metastatic CRPC. These are all retrospective analyses. They all have variability in the treatments that were applied, some using metastasis-directed therapy alone, some using metastasis-directed therapy plus systemic therapy alterations, and the imaging that was used includes conventional and molecular imaging, so not standardized, and actually multiple imaging modalities combined in single studies. These were all small, non-randomized studies that do not regularly include the currently available next-generation AR antagonist treatments that we know can prolong survival in the non-metastatic CRPC setting. Outcomes may not be meaningful and include things like time to next therapy and PSA response, and also may not be rigorously documented, like post-treatment imaging that's supposed to measure progression-free survival not being standardized because these were not prospectively designed trials but are rather retrospective reviews. The EAU guidelines are quite clear. There's a strong recommendation, level 1 evidence, suggesting that we intensify systemic therapy for patients who have M0 CRPC by conventional imaging and a PSA doubling time of less than 10 months, as were those patients included in the Spartan, Prosper, and Aramis trials. As I said, this recommendation was based on those 3 studies. These were all patients who had high-risk non-metastatic CRPC with a PSA doubling time of less than 10 months. Patients were continued on ADT and randomized in addition to ADT to apalutamide, enzalutamide, or darolutamide versus placebo plus their ADT alone. The primary endpoint was metastasis-free survival, and we saw that there was a prolongation in MFS for all 3 drugs, ranging from 22 to 24 months, and this led to initial approval despite not having a survival benefit at the time. But we have recently seen updated overall survival information that was presented at ASCO and also now recently published in multiple journals, demonstrating that apalutamide, enzalutamide, and darolutamide, when incorporated into the non-metastatic CRPC setting, prolonged survival. What this really says is that earlier integration of these intensified AR antagonists actually really do mean something to patients, because when we do it later in the control arm, we are never able to catch up with the benefit that we see when we do it early in the non-metastatic CRPC setting. We also know that these drugs improve or maintain quality of life. As we can see, enzalutamide and apalutamide are associated with stable to improved quality of life by the FACT-P, which is one of the validated instruments that we have. And we know that the same is true for darolutamide, which also appears to improve bowel symptoms and urinary symptoms, at least by the EORTC QOQ PR25, which is another validated quality of life instrument for men with prostate cancer. So is this M0 CRPC or oligoprogressive MCRPC? I would say regardless of the molecular imaging results, level 1 evidence suggests improved MFS, OS, and quality of life with this intensified AR antagonist treatment in M0 CRPC. So imaging advances may blur the distinction between patient types, but applying the criteria for M0 CRPC from clinical trials is still valid. Metastasis-directed therapy is very promising and exciting, but there's insufficient evidence to do this outside of a clinical trial. And level 1 evidence and the EAU guidelines support the use of apalutamide, darolutamide, or enzalutamide for M0 CRPC because we can improve MFS, OS, and quality of life, and we may not be able to make up the difference if we don't do it early. Thank you so much for your time.
So this was a wonderful debate, and this was very elegantly discussed by Alicia Morgans. And now we really want to hear the no from Professor Jens Bethke from the University of Tübingen, where he is the vice chair. Please.
Now it's my pleasure to convince you not to use androgen receptor targeted treatment in non-metastatic CRPC. Here are my conflict of interests. I would like to talk about the EAU guideline recommendation, the definition of metastatic disease, sequencing, quality of life, PSA doubling time and time to metastasis, local treatment options, and draw a conclusion. EAU guidelines recommend the use of apalutamide, darolutamide, or enzalutamide for patients with non-metastatic CRPC and a high risk of developing metastasis based on the results of the 3 trials Prosper, Spartan, and Aramis with significantly prolonged metastasis-free survival. Latest update from ASCO this year also proved the overall survival benefit for these 3 agents. Now it's a little bit like the story of David and Goliath. In this overwhelming amount of data, I will convince you not to use treatment in non-metastatic CRPC. And as an assay of Troja, they are also the Trojan horses. So what do Prosper, Spartan, and Aramis hide in the all-comer population? If we refer to the patient presented, do you really believe that this patient is non-metastatic with a PSA doubling time of 1.7 months? If we look at the PSMA PET scan, we see the positive non-regional lymph node, and we believe this patient has metastatic disease. But in the non-metastatic CRPC trials, patients were only evaluated by CT scan and bone scan. They were not evaluated by PSMA PET scan, and this cannot definitely exclude patients with metastatic disease in these trials. In addition, in Spartan, for example, patients were included with M1A metastatic disease as defined with lymph node positive disease in the non-regional lymph nodes. Here, patients below the aortic bifurcation were defined as N1. This is not correct according to the AJCC definition, which defines N1 positive disease as lymph node positives below the bifurcation of the common iliac arteries, and M1A disease as lymph nodes below the aortic bifurcation. So this definitely had an impact on the patient and survival results in Spartan. 16% of patients were N positive, and the predominant effect of apalutamide was in this CM1A patients. This had a bias for all comers, and the outcome of real non-metastatic patients is yet unknown. The time to metastasis with placebo-treated patients was about 14 to 18 months. And what about this time frame where you do not have the use of any agent and treatment? You do not have or lesser side effects, and fatigue, hypertension, rash, falls, and even fractures definitely have an impact on the quality of life. How can you spend this time frame without any treatment in the individual patient? Well, you can do a cruise. Spend your time with your wife, your family, children, grandchildren, and even better, do a cruise with them all together. So, is there a rationale for sequencing if you have developed metastatic disease after the treatment with placebo in terms not to treat at the early beginning? Well, in these trials we had a high rate of crossover, and in the placebo arm the subsequent therapies were initiated in 56 to 65% of patients if they developed metastatic disease. So, this is no clean comparison between the placebo and treatment arm, and makes the comparison of early treatment versus late treatment very difficult. More difficult is the provement of the value of the first-line treatment as given in these trials. So, if we refer to the respective setting of metastatic disease, we have data available for enzalutamide, for example, from the PREVAIL. Here, patients had an overall survival of 35 months, and if we add up the 14 months with the placebo until the development of metastatic disease, we nearly have the overall survival of 15 months. Well, this does not really reach the 67 versus 56 months as given for the OS data from ASCO this year for the enzalutamide non-metastatic CRPC setting. But if you develop metastatic disease, it's at a low burden. And in the PREVAIL, only 50% of the patients had only lymph node positive disease. A high percentage had visceral disease. So does the answer group of PREVAIL compare directly to the placebo CRPC non-metastatic group? No, not directly. But what we know from the subgroup analysis? Well, patients who only had non-regional lymph node positive disease had a much better OS data than patients with visceral disease. What about PSA doubling times? Well, this graph illustrates that the different PSA doubling times, the shorter it is, the higher the risk of the developing of metastatic disease is present. In PROSPER, SPARTAN and ARAMIS, PSMA doubling time must have been in the range between 3 to 9 months, as the time to the developing of metastatic disease was between 14 to 18 months. So it was in between the orange and the green curve given here. So PSA doubling time as the inclusion criteria of these CRPC trials was a doubling time below 11 months. We should have a close look at these curves, the red and the blue one. Because if a patient has developed metastatic disease, what about the PCA-specific mortality and the overall mortality? Well, if overall mortality is higher than PCA-specific mortality, we do not definitely need the onset of early treatment. If we make an overlay of these graphs, this illustrates that in patients with a higher PSA doubling time above 9 months, that's the red and the blue curve, the risk of dying of other causes than the prostate carcinoma is higher. So have always a close look at the PSA doubling time in the CRPC non-metastatic setting. If you now refer again to patients with only PSMA positive metastatic disease, and if you ask other physicians from other specialties, well, we have to note that there are different opinions. Here, well, it's for the radiation oncologists, but anyway, they do not recommend the use of androgen receptor targeted treatment in the setting of oligometastatic disease, defined as PSMA PET scan. Well, there's a lack of data for the treatment of CRPC oligometastatic disease. But what we know for the hormone-sensitive setting, as given here in the waterfall plot, well, it is feasible to do that and to do that successfully. And there's a chance to go for local treatment either by surgery or radiotherapy, also in this oligometastatic CRPC setting, potentially, which needs to be evaluated. Now I would like to conclude. Well, if you think of the Trojan horse, please be aware that the non-metastatic CRPC trials also included lymph node positive patients in the non-regional lymph nodes, and these are patients defined as M1A metastatic disease. The M1 status is defined by the modality of imaging, and PSMA PET-CT defines metastasis-free CRPC, and not only CT and bone scan alone. Sequencing also includes local therapy in this oligometastatic setting. Not every patient needs the androgen receptor targeted treatment in the non-metastatic CRPC, but PSA doubling time determines the risk for the developing of metastasis and death in this patient cohort. And of course, definitely think of initiated androgen receptor targeted treatment in the non-metastatic CRPC setting if PSA doubling time is below 3 months. Well, a careful selection of patients is necessary because the best life is a life without pills. Thanks for your attention.
So, great talk. Thank you, Jens. You nearly convinced me, but I think we have to move on. And I think the last talk is the most difficult topic of this afternoon. And Alison Bertel is giving the talk on the best sequence for M+ CRPC in 2020. Alison is a consultant clinical oncologist in Lancashire Teaching Hospitals in Preston in the UK, and we all look forward to your talk. Thank you.
Hello, I'm Alison Bertel, and I'm delighted to be able to participate in virtual EAU. And I'm going to talk about the best sequence for mCRPC in 2020. These are my disclosures. So we know that this field is an ever-evolving area, and what we do today will really affect the patient later on down their prostate cancer journey. So many of the drugs are now being used in the upfront setting, both in castrate-sensitive disease and in M0 CRPC. And so we're really left with fewer choices later on downstream. What we do have, we know, are radium-223 and cabazitaxel, and then the new kids on the block, PSMA lutetium, and also PARP inhibitors. And we know that mCRPC is a lethal disease with a huge amount of heterogeneity. And sequencing is even more important now, given the increasing use of both upfront docetaxel and AR-targeted agents. And we know that prostate cancer is very heterogeneous and that we can have coexisting AR-dependent and independent tumour cells within the same patient, as you can see from both these H&E slides, the immunohistochemistry slides, and also these FISH analyses. So with that in mind, let's go on to look at the latest data. I'm going to look first at the PARP inhibitors at 3 particular studies. And this is the Triton-2 study, which looked at patients who had deleterious somatic or germline alterations in their DNA repair genes. And these were patients who had progressed on AR-targeted therapy and at least one previous taxane-based chemotherapy in the setting of mCRPC. Patients were given rucaparib 600 milligrams. And you can see here the waterfall plot in those patients that were BRCA1 or 2 positive with very significant falls in their PSA, and some of these patients still continuing on study. And there was significant clinical benefit seen with rucaparib, particularly in those patients with BRCA1 and 2 abnormalities, where at 6 months, 56% of patients had clinical benefit, with 1 in 4 patients continuing with clinical benefit at 12 months. And you can see on the right-hand side here the breakdown of benefit dependent on which type of DNA repair gene abnormality was present. If we move on to the Galahad study, this was a phase 2 study looking at niraparib dosed once a day, and again the same patient eligibility group, biomarker positive, with 1 or more taxane-based chemotherapy and 1 or more AR-targeted therapy. In this group, again, you can look at this PSA response in the waterfall plot, the orange being those with BRCA positive, and this is with biallelic DNA repair gene defects. And you can see a very significant waterfall plot of PSA response. And if we look at clinical benefit here, this is divided into PSA greater than 50% fall objective response rate and complete response rate together with radiographic progression-free survival. And you can see again better in the BRCA group than in the non-BRCA patients. But perhaps the most significant publication looking at PARP inhibitors has been with the PROfound study with Johan de Bono's group looking at olaparib in this setting. And these are men, again, with mCRPC progressing on a prior abiraterone or enzalutamide with at least 1 qualifying DNA repair gene abnormality. Patients were stratified for taxane use previously in measurable disease. But if we look at cohort A here, these are ones with the specific abnormalities of BRCA1, BRCA2 or ATM. And patients are randomized on a 2-to-1 basis to either olaparib or physician's choice, which could be either enzalutamide or abiraterone. Or if they hadn't had chemotherapy, they were allowed to have chemotherapy. And if we look at all the endpoints of the study, you'll see here that in terms of progression-free survival in this group, that those patients on olaparib did twice as well as those patients on control. If we look at the groups together with cohorts A and B, you can see that you still have a benefit in the patients with other DNA repair gene abnormalities, but not quite as impressive as in those with BRCA or ATM. But this is a very interesting slide. This looks at pain progression, and you'll see that with the blue line, this is those patients at 6 months on olaparib, and they have a significantly greater chance of their pain being controlled on olaparib than those patients on the control group. This is interim overall survival data. It's immature as yet, but you'll see that there does seem to be a benefit in terms of the olaparib. So moving on from the PARP inhibitors onto theranostics, and this is data presented very recently at ASCO 2020 by Michael Hoffman, and this is looking at lutetium PSMA compared with cabazitaxel, so an effective agent in patients progressing after docetaxel. This was an Australian trial looking at 11 sites across Australia and 200 men who were randomized to either lutetium PSMA or cabazitaxel. And the key thing with this is that patients had to have a baseline PSMA scan and an FDG PET to check for concordance across the 2 scans and to have positive disease. The primary endpoint of this study was PSA response with the standard secondary endpoints. And this is very impressive. So if you look on the left-hand side here, this is the PSA response in red to cabazitaxel of 37% of greater than a 50% fall in PSA. But compared with the lutetium response of nearly twice as much of 66% greater than 50% fall in PSA with lutetium PSMA. And that gives us an absolute improvement of PSA response of greater than 50% of about 29% in favour of lutetium. If we look at the secondary endpoints for this study, this is preliminary data, but you can see that there looks as though there are improvements in progression-free survival with lutetium compared to cabazitaxel. Now, there are a number of strengths and limitations with this trial, the strengths being that this is the first randomized study of lutetium PSMA and that it was compared against cabazitaxel, which we know is active and a clinically relevant control arm, and that there was a large difference in the primary endpoint of the study, and these patients were selected based on their appropriateness to receive this therapy. But there are some limitations with the study. We're all keenly awaiting the quality of life and the progression-free survival data, and there was a dropout before treatment, particularly in the cabazitaxel group. If we look at side effects, there was more neutropenia and potential neutropenic fever in the cabazitaxel group and more thrombocytopenia, dry mouth and dry eyes in the lutetium group. But overall, probably slightly less grade 3-4 AEs in the lutetium group than compared with the cabazitaxel group. So the take-home message from this is that patients have a far better PSA response rate compared to cabazitaxel in those treated with lutetium. It's not yet practice changing because this is not a marker for overall survival, but there are ongoing phase 3 studies with the VISION trial comparing standard of care with lutetium versus standard of care alone. What about immunotherapy? Well, this is the Keynote 199 study, which was the addition of pembrolizumab to enzalutamide with patients who had progressed on enzalutamide in this setting. And we're going to look here at two of the cohorts, those with rhesus measurable disease and those with bone-only disease who had pembrolizumab added 3 weekly to enzalutamide in those patients who progressed on enzalutamide. This study is interesting. You can see, particularly here, if you look at the combined response rates, it's around 50% of the patients with a fairly modest reduction in PSA response, as you can see here. Radiographic progression-free survival in these two cohorts was around 4 months, and overall survival 18.8 months in those patients with bone-only disease and not reached in those patients with those measured on RECIST criteria. So this study was interesting. It showed that there were reasonable overall response rates, although they were fairly modest, and that it was a very tolerable treatment. And this has been evaluated in the Keynote 641. Should we sequence AR-targeted agents? Well, no, we shouldn't. This is the CARD study, which looked at those patients who progressed within 12 months of being on either abiraterone or enzalutamide and randomized to either cabazitaxel or the alternative AR-target agent. And across all the endpoints, it was clear that cabazitaxel was significantly better in terms of progression-free survival, overall survival, time to skeletal symptomatic events. And so AR targeting drugs should not be used in sequence. It's very important not to forget imaging, remembering that patients who have biochemical control may progress radiologically, and also PSA kinetics will give us an indication of whether patients respond to ARTAs. So in conclusion, we are closer to an ideal sequence, but what we do today will directly affect what happens downstream. Sequencing of AR-targeted agents is futile and precision medicine is here to stay. So we might not be there yet, but we're certainly closer than we were yesterday.
Thank you very much for this wonderful overview about castration-resistant prostate cancer and the best sequence in metastatic disease. So, Maria, what do you believe what is really the best sequence in these patients? You are such a very good medical oncologist that I really want to know what you would choose for a patient in this setting.
So I'm not sure if this was for me, but maybe we could specify the question and ask Alison.
Is Alison here? I thought.
Yeah, Alison is
no,
here.
No, sorry.
Yeah.
Then Alison.
Sorry.
Sorry.
So because I think there are many parts to that question, and one of and on the chat there was one question about retreatment. So we have on the one hand many agents for sequencing. On the other hand, we use a lot of those agents in the very beginning for metastatic hormone-sensitive disease already. And you mentioned that conundrum. So what about retreatment in the way of sequencing, like with abiraterone? And this was one question from the chat. Would you consider retreatment
with an ARTA?
For example, yeah.
I don't really think we've got the data at the moment, have we? There are a number of studies that have been going on looking to see whether you can resensitize by addition of other agents. So one study is Johan de Bono's REACT phase 2 study, which is adding in another targeted agent to enzalutamide once patients were refractory to that. We're still awaiting the data from that at the moment. And there are a number of other studies where you're trying to resensitize. But I think it's very difficult if someone's had a treatment in a different disease state. So say they had upfront AR targeting agents, so they had abiraterone when they were castrate sensitive. Then they had a period of treatment and now they're castrate resistant. Do you go back to it? Well, we just don't have the data. But I think in terms of sequencing one after another, there is no doubt in my mind now that it is futile. We had retrospective data that showed that it didn't work, and now we have the CARD study which shows that it did. In terms of the ideal sequence, I think we're going to, in the same way that we're now talking about the patients, do you treat them with oligomets on a PSMA? I think in 3 or 4 years we're going to be looking at a fewer population of patients presenting with this disease entity, because we'll have given treatments at a much earlier stage. And there's no doubt that if you can stay longer in a pre-metastatic stage, the quality of life is certainly going to be better, isn't it, than if you wait until somebody develops a huge burden of metastatic disease. So I think this is an evolving question. I think the best treatment at the moment is if you've got a biomarker and you're positive for it, go for that treatment because it's likely to work. And certainly when I've used the PARP inhibitors, they seem to be fairly well tolerated. I think theranostics, it's so exciting. The one question that I noticed on the chat, and if I'd have had more time, I would have expounded on it, was the dose of cabazitaxel. And I noticed, first of all, this study did have an active comparator with cabazitaxel, which is used in second-line treatment, but the dose was 20 milligrams per meter squared. Now, of course, we all know that the FDA did a study looking at 20 versus 20, well, they asked for a study looking at 20 versus 25 milligrams of cabazitaxel per meter squared, and it seemed to have similar efficacy. But I have to say, I've always used 25 milligrams per meter squared, and I have I very rarely dose reduce from the outset unless patients have had problems with docetaxel or they've got a peripheral neuropathy or some other reason. So I did actually notice that as well. There's a question about radium-223 in this sequence. I think we were looking mainly at the newer agents, which is why I didn't include that. But obviously, if we'd have had longer, that would have taken part in this talk.
Well, great. Thank you, Alison. You mentioned the targeted therapies and the PARP inhibitors. And I'm wondering, are you sequencing all your patients with metastatic disease? One short answer from you. And I would like to also ask Alicia Morgans how you do it in the USA with sequencing and use of PARP inhibitors.
We only sequence in the UK if they're suitable for a clinical trial. We don't have access outside of the trial.
All right, thank you.
So we're doing germline testing and sequencing for any patient, or it's recommended at this point for any patient with high-risk localized disease end up. So all metastatic patients, there is a guideline that suggests that they can be sequenced, and for the most part, we're actually able to get that covered. There's a company that's paying for it actually for all of those patients. When it comes to tumor sequencing, we are doing that as well. Usually, I'm able to incorporate it after progression on my initial combination therapy and try to then use it at that point. But like Allison, that was mainly happening when we had the opportunity to use clinical trials. But as of May, we now, in the United States at least, have access to rucaparib and to olaparib under approved indications. And so after that first combination, whatever it is, we now want to make sure that we know whether that patient may benefit from a PARP and do both the germline and the tumor tissue testing.
I have a question. Do you do a whole genomic sequencing, or do you only check this is BRCA1, 2, or ATM, or what do you do?
There's actually, for the germline, there's a panel of about 20 mutations that end up being done. And some of them, of course, are the BRCAs, but there are others that are done looking for MSH, MLH, for potential MSI high. So we also can use pembrolizumab in this setting. And so we do identify those patients as well.
Right, so you are much better off than patients and colleagues in the UK and also in most parts of Europe currently. But I think the PARP inhibitors will be and already are an important part in the sequencing of treatments for our patients. Yeah, thank you, Alicia. Maybe one last question, Manfred, would that be okay? One last question for Jens. There is a question about the treatments for mCRPC and why you would not consider darolutamide that seems to have a better safety profile than the other agents for your patients, because the question here is it seems to have the side effects seem to be similar to placebo. Why wouldn't you allow the darolutamide for those patients?
Well, thanks, Maria. I will not say that I do not allow any of the three agents to be used in the non-metastatic CRPC setting. But I think the main message is you should make a more careful patient selection and not to put them all in as an all-comer approach, and that there might be differences in the patients which have been treated in all these great phase 3 trials. So with regard to the question of the darolutamide, well, I think it's not okay to say that there are not any side effects. So you should have a close look at that, yeah. And well, maybe the patient could give us some more information from his background on that, because I would just like a provocative question for that for him. Well, if it does not have any side effects, is it really working? So, well, have a close look at that. And so I don't want to get into the discussion which of all of the three should be used. I think this is not the time to do this right here now, because this would be a talk for its own.
Fair enough. Thank you. Manfred, I think we have to close.
You're right. We are over time already, but I think it was such an interesting debate and also very interesting lectures, great talks, a lot of information, and it was really worthwhile to be here. And I want to thank everybody, especially you, Maria, for your wonderful discussion, and all the speakers and also who sent in their questions. It was really great. Thank you very much and have a nice evening. This was the last session of today.
Thank you.
Thank you.
Bye-bye.